Okay, hi. Assalamualaikum dan selamat sejahtera. Welcome to ASOM webinar series 01 2023. My name is Muhammad Ehsan Fitri and I will be your moderator for today. For your information, this is the first webinar organized by ASOM for this year, and a second webinar, a joint webinar organized by ASOM and Roche Diagnostics Malaysia. Before we start today's webinar, I would like to introduce our invited speaker of the day, Miss Annie Low. Is it Annie Low? Yeah, it's Miss Annie Low. She is the MS Marketing Partner for Roche Diagnostics Malaysia, and she graduated from Monash University in Bachelor of Science, majoring Biotech and Microbiology. For today, for today's talk, I believe she is the best person to deliver the title of Infectious Disease Testing, as she has overall 10 years experience in diagnostic healthcare segment handling infectious disease testing, especially in serology testing. Without further ado, I would like to invite Miss Annie Low to present the talk today. Welcome.
Thank you, Ehsan. Thank you for the kind introduction. Let me quickly pull up my screen right now.
Okay.
For those who think what does MS stands for, right? It's actually the molecular, it's a short form for molecular solutions.
Molecular solutions.
Yes. So besides serology, I'm actually covering the molecular as well. So let me, okay, can you see my screen right now?
Yes, I think everyone can see it clearly.
Okay, good to hear. Okay, without further ado, let me quickly start my talk. All right, so thank you very much. Good afternoon and salam sejahtera to everyone. Thank you for taking your time to join us for the second webinar talk today on the topic of infectious disease. So I'm Annie Low, the marketing partner from Roche Diagnostics Malaysia. And in the next 45 minutes, please allow me to walk you through these contents on improving diagnostics excellence and increased lab efficiency for infectious disease testing. Okay, so first, let's have a quick overview on the infectious diseases, which I will term it as ID throughout the talk. So we know that ID is a tremendous medical burden with increasing demands. And based on WHO reports back in 2018, there are about 257 million people who are chronically infected with hepatitis B virus, 1.75 million new hepatitis C virus infections per year, approximately 940,000 people died of HIV-related causes globally, and not to forget congenital infections such as CMV, whereby 50 to 70% of global population are CMV carriers. So what is alarming here is that a large proportion of the infected population is not diagnosed, and in order to end this epidemics, the right diagnostics are very much needed. So to show a quick look on the overall percentage across the global health scale. So actually ID here ranked number 1 and is responsible for approximately 20% of the global health burden, which leads to about 0.5 million people suffering from DALI, which means disability adjusted life years, that is equivalent to years lost due to ill health, disability, or early death, while the other diseases such as cardiovascular and cancer are following closely behind. Generally, there are 3 main factors that creates the barrier to testing and screening. So the first one, we look at the patient barrier. So lack of information and education about the disease can the patient will think, okay, I don't know anything about this, so I won't go for the testing or something like that. And then cultural belief limiting physician contact, and then also preference to alternative therapy such as traditional medicines or Chinese medicines or so on. Okay, fear of stigmatization as well as cost. Then the second barrier is the provider barriers, whereby the clinician may be lack of knowledge on who should be screened, And then also the communication and language difficulties. It's hard to communicate sometimes across the multiracial population here. Okay, and then the last one will be the environmental barriers, whereby there could be lack of access to routine care, lack of insurance coverage, difficulty in accessing healthcare system, as well as lack of social support. For the labs, there are many other aspects that need to be looked into as well to ensure that the infectious disease testing can be well managed, such as the lab efficiency and safety, expertise in ID, regulations, efficient reagent usage, as well as the reliability across the continuum of care, and so on. So next, I would like to take you through the serology assay menu that is available in the market. So when it comes to ID, serology plays an important role in screening, and it works hand in hand with NET testing, or the nucleic acid testing, or PCR testing, to provide a comprehensive clinical diagnostic and blood safety assessment. So in Roche, we provide not only the serology testing, but also the NET assays across the different diseases portfolio. For example, STI, the sexually transmitted infection, blood safety, hepatitis, congenital transplant, vector-borne diseases, as well as the NET testing for respiratory infection, gastrointestinal infection, as well as the antimicrobial stewardship. So all in all, we have about 52 assays to meet the needs across the continuum of care, covering from screening for early detection, reliable diagnosis to link patient to appropriate care, and a complete disease management to ensure patient is moving towards the recovery direction. So in today's talk, I will focus more on the serology part. So therefore, I would like to share with you here a comprehensive serology menu from Roche, that can perform not only on the dedicated blood screening assays such as the HIV, hepatitis B, hepatitis C, and syphilis, but we also can run all the other additional serology assays such as the TORCH panels covering the CMV, rubella, toxo, and also the hepatitis A. And of course, during the pandemic, we have also come up with new assays such as the antibody SARS-CoV-2 assays. And then upcoming, we will also have the EBV and also the HCV duo assay coming up. So all these tests can actually be consolidated and run in one platform. So if there's no additional serology instruments are required to run all these tests over here. So besides the tests shown previously, so we are also going to extend our ID screening assays in the next few years to include the Lyme panel, and then we also have the hepatitis E panel, and also the dengue panels coming up. So all these are either in development or already in the proposed stage of development. So with that, I would like to quickly do a quick introduction on our latest advanced 4th generation HIV duo assay. So unlike the normal 4th generation assay that only provides you one combined result, the HIV duo test here is able to provide you two separate results, one for the HIV antigen and one for the HIV antibodies, okay, as well as a calculated combined mean result. Okay, so the separated results here are available for further information, and the assay design can bring a few benefits. And the total testing time for one assay, 2 results is 18 minutes. So on the left-hand side over here is the current testing algorithm or the procedure that most labs are actually following, whereby they will start screening the HIV testing with a 4th generation screening test without the antigen or antibody separation. And if this test is positive, most of the time they will do a supplementary test, either an immunoblot or particle agglutination. But this mainly is to detect the antibodies, right? So if it's positive, then this is a confirmed chronic infection. But if it's negative, then we want to see whether this is an early infection or not. Then you will have to move towards the qualitative PCR test. And if the result is positive, then this is a confirmed acute infection. Okay. Then on the right-hand side here, if you use the advanced HIV fourth generation test with the antigen and antibody separation test, so at one glance, you will be able to see whether the antibody is positive or the antigen is positive. And in this way, the lab can quickly decide which confirmatory test that they would like to follow to confirm the results. So all in all, it can actually help you to shorten the screening, the screening period or the testing period for this sample, and you can link the patient faster to care. Okay. Then next, I would like to go through the principle of hepatitis B screening algorithm. So most of the time, the first screening markers will always be the hepatitis surface antigen test. So this will always be the initial screening test. So if it's based on your cutoff, if it's less than the cutoff, okay, then it will be non-reactive and you can report it as negative. But if it's borderline or initially reactive, okay, then you will have to retest the sample in duplicate, meaning you will need to duplicate the sample into another 2 more tubes and run the 2 tubes together parallel. Okay, and if both of the samples are negative, then you can report it as negative. But if either one or both the results are borderline or reactive, then this result is known as repeatedly reactive, and you will have to proceed to do HBsAg confirmatory test. Okay. But with the help of many other hepatitis B supplementary markers, we can actually recommend you to use this stepwise diagnostic procedure to help your lab to have a clearer diagnosis in profiling the patient status. Okay, so for example, once you have to perform the HBsAg test and the result is negative, then this patient is considered negative. But if let's say it's positive, then we can recommend you to proceed to run with the 2 additional markers, which is the anti-HBC, okay, the core, and also the anti-HBs, the surface antibody. All right. So over here, if you run it in combination, right? So if only anti-HBs is positive, this means that the patient is actually immune due to vaccination. Then if the patient has both anti-HBC and anti-HBs positive, then this could mean that the patient is immune due to natural infection. Okay, and if only anti-HBC is positive and the other 2 is negative, then further tests are required to see whether this patient is at what stage. Okay, and lastly, if HBsAg is positive and there's anti-HBC positive, then confirm this patient is currently infected. So what are the further testing that you can do from here is the anti-HBC IgM test and also the HBsAg confirmatory test. Okay, so the HBsAg confirmatory test is mainly to really check whether how true your HBsAg result is. Okay, so if this is positive, then this patient is of course positive. All right, and then next we look at the anti-HBC IgM test. If this anti-HBC IgM is also positive, then this could mean that this patient is currently having an acute infection. But if anti-HBC IgM is negative, but only the confirmatory test is positive, that this means that this patient is currently facing a chronic infection. And the interval to decide whether the patient is actually having a chronic infection or not, or versus an acute infection, is 6 months. Okay, so if let's say the patient comes in and do the testing, okay, and then they have the anti-HBC IgM, okay, and then they have no anti-HBC core. So that means that this is an acute infection. But over time, if the patient is not treated in time, then there will and after 6 months, the patient will still have HBsAg, okay, then this patient is very likely at a chronic infection. Then we will also need to see whether the immune response from the patient itself, have they start producing the antibodies to start to fight against the virus or not. Okay, so all these different markers here can help you to diagnose and state where your patient is currently at. All right, that's for hepatitis B. And then for hepatitis C screening and diagnosis, we actually have two different types of screening algorithm. So the first one is for the suspected HCV infection or for screening purposes. Okay, so we always start with the antibody to HCV test first. Okay, so again, if the result is negative, less than the COI, okay, then it's non-reactive. So this then you can stop the testing from here. But if the result is initial reactive, then of course you need to do, it's recommended to do the duplicate testing again. And then if either one of the results or both the results are reactive, then it's known as repeatedly reactive. And that's when you will have to do to proceed with further confirmatory test, which is the HCV RNA test or even the antigen test. Okay, and from here we can see whether the final result is detected or non-detected, and then we will see whether the patient is currently infected or not, and whether that will need to link to care. Okay. For the second algorithm, this is more targeted at those acute infection or those immunocompromised or hemodialysis patient, or we call it the high-risk group. So this kind of patient, most of the time, they might have some sort of interference in their blood. Okay, so maybe, how to say, very likely you will get false negative, false positive or weak reactive results. So in this case, we actually recommend to perform the HCV antibody test together with the RNA test itself. So at parallel, so if you see the results, you can see the combination of results over here. If both are positive, this is a current HCV infection. But if antibody is negative, RNA is positive, then this definitely is a current infection, okay, because they already have the virus in their bloodstream. But if RNA is negative, but antibodies is positive, it could be this patient have a resolved infection or past infection. But to be on the safe side, of course, we will recommend it to repeat the test after 12 to 24 weeks, okay, to really check whether this patient is not having a current infection at the moment. Okay, and last one is the both also negative. That means that this patient have no current HCV infection. Okay. Those are the three main ID assays that we will look into. Okay, and then in order to run this test, as mentioned earlier, of course, we provide a compatible systems to perform the task. Some of you might have already heard the COBA system from the first game on our latest systems. So there are 4 different models of COBA's immunoassay analyzers, ranging from standalone analyzers that can cater and COBA's Pure are our latest analyzers that have been launched just recently. So just to quickly show you on the COBA's Pro system. So one unit of the COBA's Pro analytics and for this COBA's Pro, we can actually chantum, okay, or how to say, we can chantum, we can mix it up, okay, up to 4 units, okay, to increase the workload from 300 tests to 600 tests, 900 tests to 100 tests per hour. Okay, so with that, the reagent positions also increases. All right. And This is how the cobas Pure system looks like. It is a floor-standing immunoassay system that can run up to 120 tests per hour with 28 reagent positions. Okay, so this is how the whole system looks like and the footprint of the system. So our assays has the shortest assay time to increase the testing efficiency, which is standard 18 minutes across most of the ID assays as compared to all the other friends in the market. Okay. And our systems also require low sample volumes to perform a combination of tests. Take for example over here, if you need to run all the ID tests listed over here, like CMV, IgG, anti-HCV, syphilis, HIV, as well as HPSAG. Okay, so the total working volume required over here is only, it's only 153 microliter. So compared to other competitors in the market, probably they will require more sample volume to perform the similar test. So in case if you need to do rerun, you actually do not have to worry so much about having insufficient volume. Another feature that I would like to highlight on our cobas Pro system is that it allows for the continuous loading of reagents and consumables as well as the system reagents without the interruption of the workflow process or having to put the system in standby, so which we call it load on the fly. So what happens here is that we have this reagent manager over here, whereby we just have to press the green button here to bring the lift up, and then you can just load in your reagent into the system. And all the while, the system can still continue to process the sample without putting them on standby. So this will not, jeopardize your turnaround time for the samples. Okay, so this is how we load the sample in. So maximum, you can load up to 5 reagent packs over here. Okay, so regardless, it can be a combination of different reagents, not necessarily from the same type of reagent or same lot. Okay, so once it's done, press the green light again, and the leaf will bring the reagent into the reagent compartment to be loaded. Okay, and with this high reagent and consumable capacity, this cobas Pro actually allows a maximum walk-away time of approximately 5 hours. So this means there are more free time for your staff to focus on other activities. Then the technology used by Roche for all our immunoassay testing is known as the electrochemiluminescence, or we call it ECL technology. It's very much similar to the CLIA method, chemiluminescence immunoassay method, but the difference here is we apply the voltage over here, okay, to start the reaction during the measurement to ensure that we are able to get a stable signal count to be generated. Okay. And the advantage of the ECL technology are as follows. Okay, the first one is control reaction. So by applying voltage, we are able to get the steady signal reading. So regardless at what time point the signal are being counted, we can ensure that we can get a very stable signal point and not a deteriorating signal point. Okay. And then we also have high onboard stability and long shelf life due to the highly stable ingredients in this reagents. Then we have the precision and sensitivity. So we have very good low detection limits and also very good precision over the entire measuring range for accurate and precise patient result. Low sample volume. So just now, the example I've shown you, if you run a combination of different tests, a maximum probably 150 microliter is already sufficient for you to perform the test. Okay, and all in all, in general, the sample volume range required is about 6 to 60 microliter per test, depending on the assay. Okay. And we also have wide measuring range. So this is the linear signal response across 6 orders of magnitude. So fewer dilutions or repeats are required. And last but not least, the rapid response time. So with a short incubation time of 18 minutes for majority of all the infectious disease assays that I've mentioned earlier, for faster reporting of patient results. Okay. Then we understand that a routine lab may also face many reactive results, and you may need to do a lot of repeat testing. So with the implementation of Cobas eFlow, positive samples can be configured to automatically re-audit and retest without the intervention of the operator. So this is a normal process in the lab, but now it can actually be automated with the use of Cobas eFlow on our Cobas systems. So let me quickly just show you how this Cobas eFlow works. So for example, you load in the first sample here, right? So you run it, okay? Then this sample comes back as initial reactive. So current practice is that you have to take it out, respin, and then after that you have to aliquot it out into two sample cups and then reload it again and order it to rerun, right? But with this Cobas eFlow activated within the system, basically the system will know that, okay, this sample, for example, is being run for for HIV, right? So now it's reactive. The system will automatically aliquot the samples into two different tubes and then rerun it again by itself. Okay, so the staff do not have to take out the sample out to do the manual preparation again for rerun. All right. So this also can help the staff, the lab team to, shorten their manual work. So by having this Cobas eFlow, all right, so with this automated duplicate repeat testing, so what you will actually get at the end of the day is with this result interpretation. So you have the initial results, what are the scenarios that you can get. Okay, so all in all, you will see that you can save the total repeat runtime with the duplicate testing without manual intervention. So initial test is 18 minutes, right? But let's say if you do this with the Cobas eFlow, you only need another additional 18 minutes to get another additional 2 more results over here. And the system itself will provide you the automatic interpretation. So it also helps you to fasten the testing time with no manual intervention required. Okay. So last but not least, so for the key takeaways, just like to summarize some of the key points that I have shared earlier on. So the continuum of ID services are needed to curb the epidemic, provides the organizing framework for the specific action to be taken. So the importance of the cascade here is really to enable the patient, okay, to get tested and then link them to care if required. Okay, and the ultimate goal that we need to achieve here is really to cure and eventually eliminate all these diseases. All right. And in Roche, we have 4 different areas with various options that can design to work together to tailor to your lab needs. Okay, so the first one is the serology part, which I have covered earlier. And then we also work hand in hand with the nucleic acid testing part. And we have the personalized lab automation, which is the pre and post analytical system to help you to have a total lab automation. And last but not least, the IT software solution to link up everything over here. And then not forgetting a comprehensive serology menu that can be performed on a single system with also the upcoming new launches and developments of new assays. And all these assays can be run in one single platform. So in a nutshell, we hope that we can be your partner to cover your needs for today as well as the future. Okay, so we can be the expertise in the ID and providing a unique, holistic integrated solution, and then having a future-proof platform and pioneering in automation to help you to have an efficient and safe workflow for faster results. Okay, so that's all for my talk. Any questions so far?
Okay, I would like to invite any participant here today. If you have any question, you can either unmute yourself to ask Miss Annie directly, or you can post the question in the chat box.
Assalamualaikum dan selamat petang. Can you hear me?
Oh, okay.
Yes.
Okay. So I have a few questions regarding on hepatitis B testing. Okay. Can you go back to the hepatitis B profile that you show to us?
Sure. Hold on, yeah.
Okay. If I'm not mistaken, this one. There are only a few markers, okay, that you have mentioned here. It's only SPSAG, anti-SBC, and anti-SBS, okay?
Yes.
For these three markers, so that we can interpret, okay, what the patient's status is, okay? But my question is, how about HBe antigen and then also HBe antibody? So where's this marker goes to the rules or the what do you call that? It's a part to interpret. Okay, is that can replace, okay, for confirmation test, okay, to confirm to acute or chronic infection, okay, because as I know, there are many hospital, okay, they didn't do the confirmation,
This
okay.
one. Yes.
Because if we look into the serology profile for hepatitis B, okay, when antigen surface antigens reactive, normally HBe antigen also reactive normally. Okay, so okay, that's the first question. Second question is regarding on the what do you call the analyzer? What probe? What the big
Cobas
one? What do you
Pro.
call that?
Cobas Pro.
Cobas Pro.
Yes.
Yes.
Must go. Okay. Compared to E601, okay, that one is more high throughput, right?
Yes. Correct.
Okay. So how much normally the workload it can be placed on the
Okay. So let me go through one by one first, yeah? So is that all for your question? 2 questions only?
so
Okay, so to address your first question, right? Okay, so I understand that yeah, this is actually the how do I say, the recommended testing algorithm, right? And then most of the time, not only for Roche but across all the other available HBsAg markers lah. Okay, so if you look at their PEG insert, they will always recommend you to do this HBsAg confirmatory test, right? Okay, but like you mentioned, I also know that a lot of labs do not proceed with this, but they will do other further supplementary tests to really see where the patient stage. Okay, so by right, if let's say it's stated in PEG insert, right, so it is a must to perform the confirmatory test. But if you are able to justify, okay, especially during the audit, that why you did not run this, so this could be a way that could help you. Okay, and what we are recommending over here is also recommended by CDC over here. Okay, so it's to run these 3 tests together, and then you can really get a better stage of that patient. But of course, this is really just to check whether the patient is whether they have the immunity due to vaccine or natural infection, or whether they are infected or not. But infected, there can be many stages also. It could be chronic infection, but they are no longer infectious. That means that it's not an active infection it's not currently an active infection. Or it could be they are still currently actively infected and they have active viral replication in them. So in this case, to check whether the patient are having that current infection actively infectious or not, that is where HBeAg, the envelope antigen marker, comes into place. Because envelope antigen is only developed when the patient is currently having an active infection. Okay, so we don't normally get patient to do the hepatitis B PCR test first, right? That PCR test, the intended use is mainly for monitoring purposes. That means that if the patient has been linked to care, and that's when we will do that PCR test for the hepatitis B. But in screening tests, we can use the hepatitis E envelope antigen to see whether the patient is having a current active infection or not. If let's say the HBeAg is negative, then of course you can also run the anti-HBe to check whether the patient already seroconverted and have the anti-HBe antibody within them or not. So with these two anti-HBe and HBeAg marker, right? So this is really just to see whether the patient is having a current active infection or not. Yeah, but with this anti-HBc, anti-HBs, then the differentiation is also to see other things like whether they are even due to vaccination, even due to natural infection, and to stage them whether they are at chronic stage or acute infection stage. So I hope that answers your question.
Okay. So yeah, thanks for the information. Meaning that compared to hepatitis, compared to core marker, okay, with the envelope antigen, okay, E antigen is more useful compared to core to replace the neutralization test if the lab not do the confirmation, right?
Yeah, I won't say replace, okay, because at the end of the day, it really depends on the auditor whether they're required to do the confirmation test or not, the confirmatory test or not. But what I can say is that you can use all these markers to help you to justify that the patient's stage, okay? So each of the markers, be it envelope antigen or core at IgM or core total, they have their own different intended use. Okay, so if you really want to have a detailed profiling of the patient, right, of course, you can run all these tests together with the envelope antigen and antibody test. But if let's say the initial stage, you just want to see whether the patient is currently having a chronic infection or acute infection, then these three tests here, together with the IgM test, will be very helpful. And then at the end of the day, it also depends on the clinician to see whether they want to see this patient is is at the active stage or not. So if they're required, then we can proceed to run the envelope antigen test. But if let's say with these three results, they are happy with it, and then they deem that this patient require treatment, then they can proceed with treatment already.
Okay, thank you.
Okay,
Okay,
thank you.
We have two questions in the chat box. For the first question is from Puan Wahida. She is requesting the copy of this slide. I think you can share it to me later.
Yes, yes.
Then I will disseminate the slide from the response we received through the attendance form.
Sure,
Okay,
sure.
the second question is from Fairuz Rizlan. May I know for HCV duo, will it test for anti-HCV and HCV-AG simultaneously like HIV duo?
Okay, I will answer this question shortly, but I remember just now there's still another second question from the previous requester, which is the E801 and the Cobas Pro and also the E601, right? Yes, there is a difference in terms of the workload. For E601, the workload is 180 tests per hour. 170 tests per hour, but for Pro is 300 tests per hour. So you can see that the throughput is actually almost double. This is because in the Pro, we also have additional measuring cells inside that can actually help to process the samples even faster. Okay. So that is to answer the second question. And then for this HCV duo test, yes, if the concept is very similar to HIV duo test. Okay, so at one reagent, you'll be able to get two results also, the anti-HIV as well as the HIV antigen result. Okay, but this test, it's already globally launched, but unfortunately in Malaysia, we are still waiting for the MDA approval. So hopefully once we get the MDA approval, we'll be able to launch it quickly in Malaysia. Okay.
Okay. I hope Miss
Roughly
Annie
when is it?
already answered. Yes, Cik Suhaimi?
Any?
Yes.
Roughly when is it for the combo and NTACV? Hepatitis C combo?
Okay.
Roughly.
We have actually
This year?
submitted. Hopefully, we can get it by end of this year, because according to
End of this
MDA
year?
requirement, hopefully end of this year or early next year, because according to the MDA requirement kan, untuk infectious disease, it actually takes about 18 months for approval. So we really hope that we can get it as soon as possible. Yeah.
18 months. I think 18 months, the new version or the new technology will already come out from others.
Yeah, we are also thinking of the same, but I think so far we haven't heard
We
of
need to discuss
anyone.
with the MDA lah in detail. Why the what they call the criteria, the requirement sometimes, you know what I mean?
Mm,
Okay. It's too tedious.
yep, understand. Yeah, we will work on that definitely. Okay, so lastly, so thank you for your attention. For those who are still here, please scan this QR code here to fill out the Google form for your attendance and also for feedback purpose. Yeah.
Yeah. I also have shared the link in the chat box. So please fill in the attendance and feedback. Okay, thank you, Miss Annie.
Thank you very much.
Before we end this webinar, I would like to invite Encik Zuhaimi, the Secretary of ASOM, to give speech. Encik Zuhaimi?
Okay, Assalamualaikum dan selamat petang sekali lagi. Okay, first of all, thank you very much to Miss Annie, okay, from Roche. A very interesting topic that presented just now. And there's a lot of information that we can share and that we know about the ID infectious testing. Okay, so I just nak buat pengumuman few things about the ASOM. Okay, first kita akan buat satu conference, okay, on May 8 dan 9. Okay, so we are hopefully that many of pegawai sains will be involved to participate this conference. Okay, that's the first. Second, I've get many question from pegawai sains, especially for MOH. They are quite confused between ASOM and PPSM. Okay, so I'm very glad to say here that these two society is different. Okay, ASOM is Persatuan Pegawai Sains Kementerian Kesihatan. Okay, the other one is Persatuan Pegawai Sains Malaysia, which is overall, or it, what do you call that? We cater all the pegawai sains in ministry, MOH, and also other kementerian ministry, okay, including private also, okay, and have a different objective for these two society. So you can register both, okay, voluntary, sukarela, tidak ada paksaan, ataupun you nak salah satu also can. Okay, so that's the second thing. And the third thing is for now, okay, I'm still pending for the registration of ASOM members. Okay, until we finish the technical part, okay, for registration form, then I will share to you all for the link registration. Okay, and also for payment annually ASOM fee. Okay, so just wait for the announcement and I will share the link later. For the good things is for this year, we are starting to send e-card membership, okay, through email after you fill up the Google form. And this e-card membership can be printed by you, okay, and you laminate and make it as a card member. So this as a proof that you are what do you call member of the ASOM. Okay, I think that's all. And once again, thank you very much to everyone, actually to the speaker, Rustia, and all the what do you call pegawai sains involved this webinar attendees. Okay, support
Okay.
dan terus support. Thank you so much.
Okay, terima kasih Cik Zuhaimi. Before I end this webinar session, I would like to thank Miss Annie for your time and your sharing today. And I do have several announcements to make. Before that, let me share the screen first. Okay. Okay. As mentioned by Encik Zaimi just now, ASOM will organize our fifth ASOM Scientific Conference 2023 that will be held in 8 to 9 May 2023 at Summit Hotel Subang USJ. So just wait for the registration link to open and we will share it through email and ASOM group. Secondly, ASOM is launching our official YouTube channel. You can access the channel from the URL shared on the screen, and the recording of this webinar will be uploaded to YouTube channel of ASOM. And lastly, to all Chinese science officers, I will on behalf of ASOM, I would like to wish a happy Chinese New Year 2023. That's all from me. Thank you. So you can scan the QR code again to fill in the response and attendance form. Thank you very much.